Hello, this is Chris Peters again. I'm continuing on with upper extremity joint MRI with an elbow MRI. I have a routine elbow MRI protocol pulled up today for us to review. Our routine protocol encompasses 3 planes: axial, sagittal, and coronal, and we perform each plane T1 and on the top here and PD fat sat on the bottom. And so my typical search pattern starts with the biceps tendon and the triceps brachii, the triceps tendon. I start with the biceps. The T1 is very helpful for just finding anatomy if you're having a hard time finding or characterizing anatomy. So I find the biceps, which is going to be anteriorly here, and it's going to follow essentially kind of follow, if you will, the brachialis muscle into the antecubital fossa here. So here's our biceps coming down. Here's on the PD fat sat. Brachialis is just deep to it. The brachialis is going to go to the ulna, and our biceps is going to go to the radial tuberosity, proximal radius here is our biceps tendon. So I usually try and find that on the axial, and I'm certainly also looking at our sagittal and coronal, especially if I'm troubleshooting a tear of the biceps tendon. You can kind of see it here on the sagittal, kind of diving in through the anterior part of the elbow. The biceps, distally, there are 2 heads of the biceps tendon, a long and a short, or short and long head, which kind of blend together to insert on the radial tuberosity. The long head is shorter and inserts first, and the short head goes further and is longer. That makes sense. That's kind of how I try and remember things. After I look at the biceps, I look at the triceps tendon. The main sequences are going to be our sagittal and axial for that. Posteriorly inserting on the olecranon here, and then scrolling back superior here. I look at the muscle and the myotendinous structures of the triceps and its insertion at the olecranon. Our long head, our medial head, and lateral head of the triceps coming down here. So I continue on after that to look at more tendon anatomy in the elbow is how I do my search pattern. So I'll look at the common extensor tendon origin, lateral elbow here on our coronal sequences, looking for pathology there, often called lateral epicondylitis or tennis elbow. Tears of the tendon typically start anteriorly, but I'll look at the coronal. And I certainly will look at the axial, help characterize any pathology or tear, as well as the sagittal can certainly be helpful as well. Do the same thing for the common flexor tendon origin next on the medial portion of the elbow. Here, medial epicondylitis or golfer's elbow is another term for that. So then certainly, again, we'll look at the axial and sagittals to evaluate any pathology there. There's a little bit of edema in the flexor digitorum superficialis. So after those tendons, I tend to look at the ligaments. And there's kind of really 2 main ligaments we're going to be looking at in the elbow. So laterally, I'm going to be looking at the radial collateral ligament here, extending from the distal humerus to the radius, and it's just along the deep surface of our common extensor tendon origin. And it's not uncommon to have pathology involving both. If you have tendon pathology, it's not uncommon to see a partial tear or tear of the radial collateral ligament, and vice versa. So I tend to start there, and then before I go to the medial side of the elbow, I look for the lateral ulnar collateral ligament, which has an oblique course posterior to the proximal radial head here, the radial head and neck. And we don't always get a great look at it, but you can see this oblique structure coursing behind the radius here. That's our lateral ulnar collateral ligament. So I'll look for any pathology or edema there as well. Next, I'm going to look at our ulnar collateral ligament. There's 3 bands or 3 components to the ulnar collateral ligament. The main one we're going to be looking at is the anterior band here from the humerus to the ulna. It's going to look a little bit thicker at its origin proximally here, and then it's much narrower as it inserts distally. So there's a little bit of edema here involving the ligament here, but otherwise it's largely intact. But that's where I go to next. I look at the the ligament there. You shouldn't have much fluid undercutting the distal insertion. You can have really a tiny bit, but usually not much fluid undercuts or strips underneath the distal ligament there. Another ligament I will tend to look at or glance at is our posterior band here along the cubital tunnel, the posterior band of the ulnar collateral ligament as well. I'll look there. So after I look at ligaments, I also look at, I move on and look at joint fluid and cartilage of the elbow joint. The sagittals, in my opinion, helpful for quantifying the amount of fluid in the joint. And then I also look at cartilage, which are PD fat sets. Of course, are going to be really helpful for evaluating any areas of cartilage loss or defects, osteochondral lesions throughout the elbow joint. So after I look at joint fluid and cartilage, I look at marrow, so making sure that we have bright T1 signal marrow, looking for fractures, contusions, and alignment of the elbow joint. After I look at alignment and marrow, some of the more miscellaneous things I'll look at the end are neurovascular structure, so nerves. I try and find each nerve. I'll start with the ulnar nerve, which is going to go through the cubital tunnel here. It should have some signal on our PD fat set and some fatty signal around it on the T1, which can be helpful in identifying as it goes through the cubital tunnel. I'm looking essentially for its morphology, any thickening, and increased signal within it that might suggest some neuritis in the ulnar nerve. After the ulnar nerve, I do try and also kind of quickly identify our radial and medial nerves. Our radial nerve is going to be out lateral here, deep to the brachioradialis. It's going to split into a superficial and deep branch about in this area. You can see the fat's helpful in finding the two portions of the nerve here. The superficial stays anterior, and the deep branch is intimate with the supinator muscle as it goes towards the posterior part of the elbow as the posterior interosseous branch. After the radial nerve, and I'm just looking for masses and signal abnormality along the course of the nerve or anything that might be impinging upon the nerve. Finally, I look for the median nerve, which is kind of anterior and medial, which is also going to go through the anterior part of the elbow, deep to the pronator. Here it is. And again, looking for any masses or signal abnormality along the course of the nerve. Look at the cubital tunnel. I really look at the cubital tunnel when I'm looking at the ulnar nerve. And then finally, I'm just looking at the rest of the muscles around the elbow for any signal abnormality or pathology elsewhere. And that's my search pattern for the elbow.